and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Raajit Rampal from Memorial Sloan Kettering Cancer Center and Dr. Brady Stein from Northwestern University Feinberg School of Medicine in Chicago, Illinois. They will be discussing how they tailor current treatment options for different patients with Polycythemia Vera, depending on their presentation and previous medical history. This episode is part of a larger educational program titled Integrating Current Evidence and Individualized Treatment Regimens into Clinical Practice for Patients with Myeloproliferative Neoplasms. For more information on the experts, along with a link to the complete program, including additional upcoming podcasts and expert commentaries, an interactive treatment decision support tool for myelofibrosis management, and an expert-authored online module covering up-to-date care of myeloproliferative neoplasms, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi, thanks very much for listening in. My name is Brady Stein. I'm a hematologist from Northwestern University in Chicago. I'm joined by my colleague, Dr. Rampal, from the Memorial Sloan Kettering in New York City, and we're going to discuss our approaches to Polycythemia Vera, and we're going to have a dialogue about what we think it's important for hematologists to know about the treatment. We thought to frame this discussion, we would start with a case. This is a 63-year-old who was initially referred for thrombocytosis. This was recognized incidentally. The patient had no splenomegaly, normal white count, and I think what alerted the primary care provider of an abnormality was the platelet count of 985,000. That's what prompted the referral, but the hematologist also noticed a hemoglobin of 16.5, a low EPO level, and a JAK2 mutation, and that led to a bone marrow biopsy, all suggesting Polycythemia Vera. So this patient, as with standard care, would start on aspirin and phlebotomy, and because he's older than 60, the most common frontline choice that most hematologists across the country might use would be hydroxyurea, so this is fairly typical. And during follow-up, the patient develops significant aquagenic pruritus. The dose of hydroxyurea is pushed, but pruritus remains poorly controlled and thrombocytopenia becomes apparent or limiting. And so the patient holds hydroxyurea, the thrombocytopenia improves, and he's reevaluated. He lacks splenomegaly. And so the question is, what would we do next? So this is, I think, a common question for us about what we might do for Polycythemia Vera after the first line has failed. So I can ask my colleague, what do you think is the first-line therapy for Polycythemia Vera in 2022 or 2023?
Great to be here with you. And as I think you've pointed out, this is a common problem, right? Going back to first principles, what are we trying to achieve in a patient with polycythemia? Most commonly, what we are trying to do is to prevent thrombotic events and to control symptom burden. We know these patients have certainly a risk of disease progression, but it's I think debatable whether or not we have truly disease-modifying therapy that can prevent, progression to myelofibrosis or to leukemia. That is a big problem. But on a practical level, in a patient like this, we're trying to keep the hematocrit less than 45%, as we know that associates with, relatively speaking, a lower incidence of thrombotic events, including cardiovascular events, and to control the patient's symptoms. In the frontline setting, what do we know? As you've pointed out, right, most physicians in the U.S. are using hydroxyurea. We have a couple of randomized studies that have looked at hydroxyurea and interferon as comparators up front. And one study, at least, the MPD-RC 112 study, didn't show a difference between the two drugs, at least at 2 years from initial treatment randomization. And that included looking at not only blood counts, but also looking at bone marrow assessments. On the other hand, we've got a newly approved drug called ropeg interferon. And to head comparison with hydroxyurea in patients with polycythemia, there was overall better hematologic control, not initially, but really, 3+ years out, there was better control. There were no bone marrow assessments done on that study. And so does that mean that should absolutely be the frontline standard of care? That's a reasonable thing to say. Granted, not everybody can tolerate ropeg interferon or interferons in general, not just ropeg. And so I think that is sometimes where we run into problems is the tolerability of interferons. But, the longer term question, does that change the risk of thrombosis? Does interferon change the risk of thrombosis? Does it change the risk of progression? those are things that we don't have prospective answers for. And and I think that's why it's difficult to say that, one thing or the other should absolutely be frontline. Is hydroxyurea reasonable frontline therapy? Yes, it still remains so, because the proportion of patients are going to still have a durable response. Is interferon and ropeg interferon specifically an appropriate first-line choice? Absolutely it is. But of course, we need longer-term data to tell us more what to do. Now, as you're pointing out in this particular scenario, right, we run into a patient who has been started on hydroxyurea, develops thrombocytopenia, and has persistent symptoms. And in this setting, our options are to switch to interferon or to switch to ruxolitinib, which is also FDA approved in this setting. The blood counts being an issue, the interferon certainly could be given regardless. I think you could still have a benefit with ruxolitinib, but are we likely to affect the symptom profile? That's where things are a little bit more problematic, because interferons, as you know, can cause pruritus themselves. Whereas with ruxolitinib in the response trial, where patients were randomized to Rux or best available therapy after having hydrea intolerance or resistance, and most of the patients on the best available therapy actually got hydroxyurea, we know that hematocrit and spleen count control were better with ruxolitinib as a composite endpoint, and there was a trend towards the symptom burden improving as well with ruxolitinib. I think the similar trial that was done in Europe was done without looking at the spleen as an endpoint, but it was really about hematologic control. And again, there, the same fundamental finding was that hematologic control was superior with ruxolitinib. And so for those reasons, again, we have options here, right? And I think that in this particular patient's case, given the symptom burden and the need for a non-hydroxyurea-based therapy, ruxolitinib would be a reasonable choice.
I think those are all a number of really good points. I agree with all of those points. I mean, the frontline, I think it could be either of those options. I think everyone agrees the patient starts with hematocrit control and aspirin. Everyone agrees the patient needs cytoreduction. And I think you could make an argument for either an interferon or hydroxyurea. It's tough to say that one is definitively superior to another. I think that's where you have the discussion with the patient, and it's kind of patient selection and patient factors. So I agree with you there. I think in this day and age, if we were to choose an interferon, I totally agree it would be ropeg interferon. That study, I think older patients might be able to tolerate that agent perhaps a little bit better than pegylated interferon and certainly recombinant interferon. So I agree the first line, either of those options I think are equal. I don't think one is definitively better, and I think that's where patient selection comes into mind. In terms of the second line therapy, I totally agree with you. I also think that if you have a patient who needs a second line, if they have a high symptom burden, I'm the same way. I really don't think that interferon is the way to go. This patient has really significant pruritus, and we know that probably the best drug for pruritus is ruxolitinib. So in this patient vignette, one, we can't really continue the hydroxyurea. First, he had thrombocytopenia, but second, he's got progressive symptoms on hydroxyurea. So we have to switch, and when we switch, we sort of go back to the patient vignette and think about the prominent aspects. If this was an asymptomatic patient that had a cytopenia and things improved, then you could make an argument for salvage pegylated interferon. But when the patient has symptoms, I totally agree with you. The next step is probably ruxolitinib.
Yeah, exactly, Brady. Making a really great point, which is the conversation with the patient, right? Because the side effect profiles, when we think about first-line therapy of interferon versus hydroxyurea, they are very distinct. And we know that things like, depression are known side effects of interferon, so we have to be cautious about that, as well as thyroid and liver dysfunction, long-term, of course, pulmonary fibrosis and ocular toxicities, and the toxicities of hydroxyurea, of course, with regard to skin cancer and other things have been well described. So I think having that exactly conversation with the patient, right? And then there's the pragmatic part of this too, which is that some patients don't want to inject themselves, and which is understandable, right? And so those are the things I think that will often mitigate the decision.
I want to go back and do a different patient just to see how you would approach. Let's say you have a patient who's 38 and they meet formal criteria for polycythemia vera. They're younger than 60. They've never had a thrombosis. They start with hematocrit control on aspirin. And historically, these are patients that we would use phlebotomy and aspirin and then kind of a watch and wait approach. What do you think about that approach in 2023?
Such an interesting question, right? Because we continue to treat patients with ancient, and I mean thousands of years old treatment modality in the sense that phlebotomy is certainly an ancient thing. I think in a younger patient, right, certainly the same goals remain in trying to prevent thrombotic events. On the other hand, in somebody who's 38 years old, disease progression is a very real risk. And we want the patient to always have the longest life possible and the best life possible, right? Those are again, our basic principles. What do we know, up front? Is there a rationale to treat that patient differently than you described with a cytoreductive therapy? There is at least some data for us to hang our hands at. Two things, I think, in particular. One is that there is data recently from a randomized clinical trial presented by Tiziana Barbui with an update at this year's ASH in 2022, where there was a randomized trial done between using early interferon versus traditional phlebotomy aspirin. And there was better count control seen. And the study was actually stopped by the Data Safety Monitoring Board because the results were superior in the interferon arm with regards to controlling the counts. Granted, it was only in 127 patients or so we're dealing with really small numbers. But it is a thought-provoking trial in the sense that this is the first piece of evidence that we have prospectively that says, you know what, maybe treating patients early on with cytoreductive therapy may alter the history of the disease. Certainly, it does not prove, this study doesn't prove, at least at this time point, that you're preventing thrombosis or you're preventing progression, but it's hinting that you may better control the disease. So I think that's one thing. Second thing is that there is published data from Abuzeni and colleagues at Cornell that retrospectively looked at the Cornell experience with different agents, including phlebotomy, hydroxyurea, and interferons in Polycythemia Vera patients. And what their data demonstrated was that there seemed to be a reduced risk of myelofibrosis in the patients treated with interferon. So to me, these are two compelling pieces of data that are beginning to say to us, you know what, we may need to rethink how we're approaching PV. Again, we're lacking the holy grail of data that says to us, look, this treatment given to a younger patient will prevent them from progressing. And it would take years in a large number of patients to get there. But I think that increasingly, the evidence is beginning to perhaps suggest we should be thinking about changing therapies or how we approach this.
Yeah, that's kind of how I'm thinking as well. At least in a university setting, I think the field is slowly shifting towards earlier interventions. And that's because we have an approved drug now. And I think you're right. The data is intriguing. It's not massive data set with long follow-up, but it's really intriguing for this concept of early interventions. And I think that type of intervention is not likely to work late. Interferons are a drug that I think work better when the patient is new into their disease course. It really, not for a highly symptomatic patient, a patient who's 12 years into their disease with a big spleen and a lot of symptoms. So I too kind of see it, my younger patients, in a little bit different light, where I'm introducing interventions earlier than I might have, even a couple of years ago. Okay, so the last question I would ask you is future therapies. What are you most excited about in terms of the next novel agents that are being developed for polycythemia vera?
We're fortunate that we've got trials for patients with polycythemia, right? This is an exciting thing. And, I think it's going to be exciting to see longer term what happens with ropeg interferon. Right now, there's studies going on with higher dose intensity. I think that's interesting. There's data that Jean-Jacques Kiliagian has presented with regards to interferon discontinuation in some patients, right? Can you actually put patients into sort of a clinical remission and then stop therapy? I think that's an interesting thing that we need to learn more about. And of course, there is rusfertide, which really works by inhibiting iron uptake and utilization, and at least in early phase data presented, seems to control the hematocrit better than phlebotomy, which, is that likely to alter the natural history of the disease? I don't know. But more consistent control of the hematocrit may, in fact, be a part of the key to preventing thrombotic events, right? I think we sometimes fool ourselves when we check the hematocrit every 3 months and phlebotomize the patient. It's not as if the patient's hematocrit is only elevated on the day we see them and do the CBC. It's likely been elevated for weeks, if not days, if not weeks prior to checking the CBC, which raises the risk of thrombotic events, right? So I think that's more about having consistent control of the disease. And we'll have to see, again, with longer-term data, what that means for the natural history of the disease.
Yeah, I agree. I think that's the next agent to watch. And I think it'll be interesting because this is an injected therapy that should only control hematocrit. So we're not going to control the leukocytosis and the thrombocytosis. And I guess it'll be interesting to see which cell count is really the most important, and is hematocrit control alone enough to keep symptoms in check and to reduce thrombosis risk. Well, I think it was nice catching up with you. Great chatting. And that concludes our brief session on our approaches to what's new in polycythemia vera and what's contemporary in polycythemia vera. So thank you very much.
Thank you very much, Dr. Rampal and Dr. Stein. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, integrating current evidence and individualized treatment regimens into clinical practice for patients with myeloproliferative neoplasms, please click on the link in the show notes. As always, thanks for listening.